welcome back, everyone. We will now transition into the full speaker panel. And this is a great time to ask our interdisciplinary panel any questions you may have or any questions that you had previously that weren't answered. So the floor is open for questions. Just go ahead and type your questions in the Q&A box. And if you'd like to have your question directed to a specific panelist, just go ahead and indicate that as well in your question. Okay, so our first question is, how will this affect the flu season? How will the COVID-19 pandemic affect the flu season?
Well, if nobody wants to jump in, I'll jump in because old people get a lot of flu. Depending on how good the flu vaccine is this year, we're going to have a problem with not knowing when people get sick, whether they've got COVID or flu. We're going to have to look at them carefully. It's going to be an ongoing problem. And if people don't get the vaccine, and I think one of our speakers suggested that Americans would get their vaccine. Most of the time, it's about 50% of people will get it. We've tried forever in the nursing homes to get it up to 70% where you get herd immunity, and we have problems all the time. Americans do not like to be told they've got to do something. I was alive when we had to wear seatbelts, and every one of us wanted to kill people who thought we should wear a seatbelt, and the masks are the same sort of thing, and the vaccine, we've got tons of anti-vaccinators. So we need to, in some way, get people to do all the things they're supposed to do. Masks obviously will help decrease influenza as well. And obviously, we're at the risk of seeing people getting both influenza and COVID together, and we have no idea what that will do. So I think the biggest thing is we need a government that says that people have to get their vaccines for both and that they have to wear masks. And if our leaders don't do those things, quite honestly, I mean, I'd like to see our president get his vaccine as the first vaccine on TV so we can watch and everybody knows that it's safe and worthwhile getting, you know, and do the same thing for flu. This is what I've done in the nursing home for years. I'd go in, let them give me the first vaccine in the nursing home, scream like mad, so everybody came running after I got it, and they basically, I'd say, it wasn't that bad. And, you know, we have to do things like that. You have to put a lot of effort into making people feel that these things are important. So I think it's going to be a big thing for all of us, the students, all the physicians, the social workers, everybody to say to people, we need to do it. Because one person who says, well, you don't really need to do it, is going to be sufficient. And the concept at the moment that maybe only 50% of people would have a COVID vaccine if it came out, and that's if it's safe, you know, and unlikely that this year we're going to know for sure when they come out that they are really safe. So I think it's extraordinarily important that we pay attention to both, and it's going to be a tough winter, I think. I don't know if Dr. Dobbs has different views.
No, I was actually just thinking about that. No, I agree. It probably will be a pretty tough season. We don't know what the flu season is going to look like this year, and I do predict there will be more demand for the flu vaccine this fall. And actually, we've ordered more than our usual number of doses in anticipation. But it's going to be hard to discriminate between COVID-19 and influenza when you're seeing patients with it. And we'll have to do a lot of testing in both, which is really what we did anyway, back when the outbreak was starting and flu season was still going on.
Yeah, I think we've got to hope we've got a quick, good antigen test that works in time or for the COVID, or
Right.
It's going to be a disaster because, you know, if we don't know, we don't know.
Mm-hmm.
Another attendee asked, since gyms are open now, what guidelines do you recommend for individuals that want to go work out at gyms?
I wouldn't go, but I know Dr. Thomas, I'm not sure if he's actually able to still be on. He goes. He probably could give some guidance. Dr. Thomas is a weightlifter. He may not be on.
He's muted anyhow if he's on at the moment.
I would say, really be careful with social distancing precautions. Kind of like when you're in a location where people are speaking loudly or singing, and probably there's more virus in the air. Where people are breathing hard, such as in a gym, I think it's more likely that it could be in the air too. On the plus side, you're not as likely to have people actually with COVID-19 there because, many of them are going to be symptomatic and not feeling like going to the gym, really. So that may be one of the reasons we haven't seen as many cases that are traced really back to the gyms. But personally, I wouldn't go. I would exercise through other means until the pandemic passes.
Yeah, I think the other thing is it depends on the gym's ventilation as well. A gym that spaces out and has good ventilation is most probably relatively safe. A gym that doesn't space people out and fundamentally has lousy ventilation is going to be a problem. It's up to the people making the decisions where you're going, whether or not the ventilation in your gym is any good or whether it's just pushing the air straight back in from one person to another, because that's like giving you a nice whiff of COVID every time it pushes it back in. By the way, there was one earlier question I might as well answer, which I wasn't certain, so I went and looked up the answer, and that was about pregnancy. And the answers, I don't think anybody answered it. The question is not clear. I mean, the question is clear. The answer is not clear. And but it seems that women who are pregnant are more likely to be hospitalized, and they're more likely to get into an ICU. But this may be extra caution by the physicians. There's a small amount of data suggesting that some miscarriages may be a little more common, and there are a few reports suggesting that mortality amongst the women who are pregnant might be higher, but those seem to be more or less case reports. So as I look at it, I don't think we can clearly say at this moment in time. There is some thought that somebody should collect the data from Wuhan, where they had a lot of pregnant women, and I haven't seen that published at the moment.
Our next question is actually for Dr. Edwards. What recommendations do you have for us to make the best we can given the current economic projections?
Yes, so I think that I'm interpreting this as how do we make the best we can in terms of our jobs and applications and things like that. So the most important thing to remember is that no one can take your education or training away. Right, you can have a rough start in the labor market. You can have a hard time finding a job, but you have a specific training and skill set, and you want to work in health, and that's always going to be in demand. And so I would say the most important thing is don't give up hope if you hit a rough patch, because you have an excellent education and you have a skill set that's going to be in need. And at the same time, there's a little bit of a doom and gloom aspect, which is to say that sometimes when the job market is really tough, a lot of what we think are the lasting effects are driven by people who are greatly affected, which are unlikely to be people who have more education. So there's a chance that, it's a little bit overblown for worry in your case. But the health sector has taken a hit because there's been a reduction in non-elective or in elective services. So that said, the outlook is not good. But it will improve when the vaccine kind of changes, or when the pandemic is effectively contained. We're more likely, when we do have a vaccine, that the demand will increase. And especially in health, the projections are there's going to be an incredible demand for healthcare after the pandemic has cleared, for the number of appointments and procedures that have been delayed in the meantime. I have talked to one of my colleagues who works on telehealth practices, and it is a skill that I think probably wasn't necessarily valued that highly in the labor market beforehand, because health is so personal. But I think if there is a training, if there is a class, if there's something that you can look into to understand how telehealth works, to be more familiar with it, I wouldn't be surprised if some health companies are starting to shift to understanding how telehealth could affect their bottom line.
Perhaps I could add to that. I think for the social workers, and I know we've got a lot of social workers online, what I think we've seen in the time of COVID is the need for outstanding social work, and many more than we have. You know, the African American Black disparity is mostly low socioeconomic group in an inability to provide the services. And I think that if I was a social worker, I would be agitating for the government in all their CARES plans that they may or may not be giving us and so on, to give a large amount of money to social work to get out there and to actually develop a better social work plan that we have for the low socioeconomic group, and provide money to help that group out, because that's where the long-term economic problems are going to be. As far as telehealth, I've got an interest. I actually own a telehealth company at this stage that we've just started, and I think it's going to change medicine. I think those of us in medicine have been very complacent, believing that we're so good that we don't need AI, we don't need all of these things. And I think we're going to see, certainly in health, but also in every section, that jobs are going to disappear to high quality telehealth. There's a lot of stuff in medicine that can be done as well, if not better, by telehealth. All my physician friends tell me that's not true because they're so important, but I work with a large number of advanced practice nurses, and I realize that most of them can do as well, if not better, than physicians, because they actually spend some time listening to the person, whereas many physicians forget that that's a part of our job. You know, so I think that there's going to be big changes brought about by COVID, and it's going to be very difficult to say just where things will be when we come out of COVID and what jobs are going to be important. I think where obviously the jobs for higher educated people are more likely to survive, but I really do think that we're going to see a total change as many people are working on multiple ways to use AI to replace human beings, and that's going to be the big problem that we had to get to sometime, so it was going to come. I think COVID's just pushing that forward. I don't know, Catherine, if you agree with that or not, but I'm terrified of what this will actually do to jobs out there.
So, yeah, and is it all right if I'll just keep going? So, you know, automation and, you know, technological advances, they get a really, as an economist, I think it's better to approach them somewhat agnostically, right? They're not necessarily bad for people or necessarily good for people. I mean, hopefully they're good for the economy because they accelerate production, and that frees up time to do other things. And we're glad that we have new technology. I think technology gets a bad rap because, and of course, remember, I don't speak for the RAND Corporation, but a lot of our public policy is faced to hate poor people. So, I mean, I would say, you know, automation and job loss is a concern because we don't actually have a lot of resources for people who have lost their job. And that doesn't make technology bad because public policy isn't pulling its weight in helping people transition if the economy is changing. And so I think that definitely probably echoes what some of what the other speakers have said of where this vulnerability comes from. And so there's this temptation to be somewhat of a Luddite and say, you know, there's too much at risk. If we automate X, Y, or Z, we'll lose checkout clerks, we'll lose these jobs or other jobs. And I'm not concerned. I mean, we have progressed so much technologically as a country, and our most vulnerable people don't come from, our most vulnerable part of the economic population or the economic perspective don't come from jobs that were automated. They come from jobs that pay very, very little. So kind of like a coda on that, there's a very famous economist who just like hates talk of technological progress. And he makes this point when we think about how like the world is changing at this incredible pace. And he's very much a cynic in this respect. And he says, if you put yourself in 1940, right, and you were to go 70 years backwards in time, you would not be able to live. You wouldn't have electricity. You wouldn't have the telegram. You wouldn't have the phone. You wouldn't have car. You wouldn't have cities. You would be living an agrarian lifestyle or a horrible factory life. But you would have very little ability to survive. But if you were to say, take someone from 2010 and send them 70 years back in time to 1940, like maybe you'd be bored, right? You know, maybe you wouldn't have your phone, maybe TV would be terrible, but you would be able to function mostly as you do now. And his point is that we put a lot of emphasis on whatever is the next fringe, but the most advanced technological innovation that could ever have come out of the economy has well passed us by. And now we're kind of like adding to the margin, but we're not reinventing the world the way that we already have. And I kind of find that to be comforting when people tell me that jobs are going to go away because a machine is going to replace them. Because for the most part, you know, our economy hasn't changed that much in 70 years, even though it was before the advent of the internet and those things. So that's just a kind of like a comforting thought.
So I should just remind you, in 1940, Watson, who came up with IBM, said he thought there was a place for 3 computers in the whole world. So we have come a long way and things have changed. I think things, when they change slowly, are good for the economy. It's if they change quickly. I mean, 40 years ago, I actually believed that computers could, I was an endocrinologist, and I really couldn't see why a computer couldn't do everything I was doing slightly better. It's taken till now, and we still don't have endocrinologists who just measure whether things go up and down. You know, they measure them in the blood. This requires nothing that is good for a human being and is ideal for a computer. And we move slowly, but it's at stages like this, you see big changes in the world. You know, it's when suddenly you get a car. You know, the first car changed the world dramatically. The first plane changed the world dramatically. And I think we're about to see dramatic changes from AI. And I'm a little worried COVID did it, but you know, we'll see how it happens. I hope you're right. I much preferred your viewpoint of the world than mine.
Well, the good news about economists is that unlike people in health, we get to have however many viewpoints we want. So it's just, whatever you say, I can find something that says the opposite. No problem.
No question.
I'm mainly kidding.
So the next question is asking if there are any multidisciplinary studies that are underway to address the larger public health issues like health and social injustices and inequalities.
I'm aware of quite a few, but I couldn't go into the details.
Yeah, I mean, I think there are a large number of studies that people are doing, a large number of epidemiological studies. I don't think we have done a great job at setting up studies where we are going to fix social inequalities and see whether, as we fix them, that cuts down on the COVID problem. And you know, to fix social inequalities requires huge amounts of money from the government. And this is not necessarily a time where we're going to see somebody decide to put that money in. You know, it's very difficult to design those studies. And I don't see a great enthusiasm in the country at the moment to say we need to cut down the amount of money that the rich are getting to allow the poor to get more. And that's basically the biggest fix we need. I mean, that is a huge population health problem in my mind. When I look at population health, I see that one as most probably the biggest problem is how do we fix the inequalities in the amount of money that float around from some people to others. I mean, I'm well off, and so I should say that I'm not certain I really want all my money taken away to be given to other people. But on the other hand, I do believe I should be prepared to give up some of it so that other people can do a little better.
Our next question is kind of a two-part question. So what do we know about immunity so far regarding COVID-19? And what are some of the long-term health effects of having the virus?
So the immunity John Thomas went through to some extent, there is actually, and Michael might know more about this, I read it all the time. I realize that it totally screws up the immune system, and particularly when you get to the inflammatory COVID storms and things like that. And, you know, it clearly alters the whole immune system. And with a bit of luck, the immune system wins the fight early on. Otherwise, you don't do very well. The long-term effects I showed in that diagram of the guy, and I was going to respond to that and mention it when I gave the talk, but those are there, and they basically are huge, and they are seem to be a different amount of time for people. I mean, we haven't had any long-term time to know, but it's clear that some people are taking months to respond at this stage, get better. We are clear that some of the older people are not being able to remember nearly as well. They are having a deterioration in the way they think. Some people seem to be left with joint pains. Some people's anorexia, not the anorexia, but there's problems with smell and taste don't come back. And all of this is there. And obviously there are people who are having strokes and stuff who are going to take a long time to come back. So it's a really complex area as I see it. And we just don't know. I mean, if you ask me this question in a year, we're doing some epidemiological studies, and we would most probably, or my colleagues would most probably be able to give you some of those answers. We're looking at the people in the nursing home, and some seem to have low-grade COVID and bounce back without any trouble, and others either die or are left with a major deficit. I think it's like any disease. Remember, if you go into hospital, they do nothing for you in hospital. You lose a kilogram of muscle weight, muscle within basically 3 days of being in hospital if you have inflammation. That takes forever to put back. And we don't treat that in hospital at the moment. It's most probably the biggest thing we should be treating, and where people have started to pay attention to it, they're showing that you can slow down that loss of muscle. If you go into an ICU 5 years later, you have not caught back to where you should be. This data is there now, and we know, you know, some people are getting people in ICUs off the ventilators onto bird machines so they can walk them around in the ICU to see if they can improve outcomes. I think we've got to start looking at how we improve outcomes in sick people in hospital, because we won't know until we start to do that whether that's where the problems from COVID are, or are they the problems of the disease itself, which affects almost every organ in the body. The ACE2 receptor is everywhere. Michael, do you have any additional thoughts?
No, I'd say you actually summarized that very, very, very well, and it's in alignment with everything that I know or think about it. So
I should point out, when I first tried to get somebody to take something like cachexia in people with COVID, the editor of the journal, and this was writing an editorial, told me I was stupid and it had nothing to do with it. And then a month later, he came back and said, hey, maybe you're right, and maybe we should have something on cachexia. I think I understand that we need something on cachexia, but he wouldn't admit that I told him that in the first place. You know, this is how journals work, by the way. For all of you who may be writing articles, have no faith in the editors, have no faith in the reviewers. They all are crazy. They all make mistakes, and you just keep on trying. Some of my best papers have been rejected 5 or 6 times, and then they cite it forever. And some of my really bad papers get into good places instantly. It makes no sense. So just for the students, remember your life. It's going to be a strange life we live in, because that's what the world is.
And we have a question actually directed for Ms. Rivera. So prior to COVID-19, some insurance companies in some states have been not covering telehealth services or mental health telehealth services. Have you seen a change in this, considering the pandemic limits some people's access to care?
Yeah, well, I think it depends on your licensure, right? So I'm a licensed clinical social worker, and there are some states that will allow us to practice in their state with certain permissions. We have to contact their state board. because now we're practicing in you know, wherever the client is located. I'm only licensed to practice in the state of Texas. So an example of this would be if I had a student that went to, for example, California and New York did not allow anybody to practice outside of their states. And so if I had a student that went to California or New York, by me contacting them isn't going to make any difference, right? So with insurances, it's very difficult because all insurances are different across, you know, the nation. And so we want to make sure that we get not only permission from the state boards, but also through the insurance companies. It is very difficult. It's difficult, one, to get a hold of state boards and licensures because they're overwhelmed. Right now, the state of Texas licensure board is making a huge transition from a certain board to another. And so they're offline for 2 weeks, which is probably not the best time to be making that transition right now, right? So the best answer I can give is, have I seen any changes? Probably not as easy as they should come during this time.
Yeah, at SLU, we've been doing cognitive stimulation therapy for about 5 years, and it turned out that we could get speech therapists and OTs covered to do it in person, struggled to get psychologists, quite honestly, which made no sense, and couldn't get social workers. We've now got social workers. I know people, we work with CMS very heavily to get this stuff covered. The world is changing, and CMS has suddenly bought into telehealth. And I think this is the time where, particularly for the mental parts of telehealth, you know, the mental illnesses, we need to strongly go to CMS and say these things can be done. Social workers are one of the ideal groups to do them. Certainly CST can be very well done by social work, and CST, by the way, works better than Aricept or any of the drugs for dementia. We've got good data for that, as do the people in England. So, you know, realistically, I think it's going to change. But again, it's going to take every student out there who wants to do this sort of stuff to agitate with the local boards and also with CMS and the insurance companies to cover it. Nobody wants to pay for anything. It drives me crazy. You know, they'll pay for stuff that's really expensive, like remdesivir, which hardly works, by the way, just in case you thought it was a great drug. It hardly works. Apparently, they paid for hydroxychloroquine, which didn't work. So, you know, but when it comes to doing really good things like social work and some of the psychotherapy stuff, nobody wants to pay for it, and it's much harder to get it paid for. And I think it's really important. Nobody pays for geriatricians to spend an hour with a patient. We're the least well paid of all specialties, even worse than pediatricians. And the pediatricians and geriatricians are the two who spend some time talking to their patients and actually trying to help them, as opposed to just giving them a drug and telling them to leave. Now, that's not fair to all physicians, and many GPs do very well, but realistically, we have to recognize that we need to change what the role of people are interacting. And Valerie, you can go out there and agitate for social workers. I think Marla Bergweger, who works with me, agitates for them all the time. So we do need to do that agitation, because it's a totally underpaid. You vie with dietitians as the two most underpaid groups of people, and yet may be the most important groups of people for keeping people happy and functional. So the students in those areas, you're going to have to fight to get well paid. It's just unfair.
Yeah, I wanted to add something very quickly. Insurance companies are providing coverage, but most of them right now are expiring. And what that means is that they have a limit, right? So some are expiring at the end of August, some until September, and then others have already extended all the way till the end of December. So what that looks like after those expiration dates is going to really be dependent on what the client and therapist want to do after that, if insurances are not going to cover those therapy sessions.
I think CMS is going to continue to cover most of it. I think they've accepted that this is a new field, and it actually is, in the end, somewhat cheaper than having people come in to see people, and will almost certainly be cheaper. You know, you won't get quite as much money, but nevertheless, you'll get well paid because you don't have the the time in between the people not turning up and stuff. So I think CMS is going to go that way. Hopefully they will force the insurance companies, who I have absolutely no faith in. Michael might again have more faith in insurance companies than I do, but I really don't know why we have them. I think we desperately need a universal health care system. The VA does at least better than 50% of physicians, and it costs much less than does the rest of our system. And the VA has a lot of problems, which I think are fixable, but realistically, they've shown that you can't do worse than half of the physicians in the country by having a universal healthcare system. That will annoy at least 80% of my physician colleagues, so I should shut up.
It doesn't bother me.
I saw you smile there, Michael. I felt much better. You have no idea how many people I bother with my outlandish viewpoint of how the world should be. And I understand it's outlandish. So for the students, realize any version of life I have is most probably totally outlandish.
So we have one more question directed to Dr. Dang, but it'd be really great to get all of your responses on this question. What do you think is the #1 public health lesson we should take away from this pandemic?
I would say that the public health lesson that you should remember is the importance of prevention over treatment. So a lot of the speakers mentioned that the treatments really aren't effective. I mentioned that remdesivir, dexamethasone, if they're recommended, again, these are patients with severe disease, so we're not seeing a lot of mortality benefits, which is what we want to see in the end. So preventative strategies, things like vaccine development, things like quarantine, social distancing, wearing masks, are really important public health lessons, because sometimes the most effective way to cure a disease is all about prevention strategies, making sure that there's protocols in place to prevent people from being positive than actually treating the positive cases.
So I would agree with you, and I'm showing you my hamster with his mask. I know people like my COVID, but my hamster is even cuter with a mask, and he was the best study to show masks work, where they had hamsters in one cage who they infected, they put a mask between that and the cages next door, and at the cages next door where they had the mask, 70% of hamsters didn't get infected, where they didn't, 100% got infected. So I believe in masks because of my hamster. Very important to have animals that are plush and tell you this, but I think it's really the preventive medicine pieces, as have always been for all the pandemics, going back to the first pandemic in Greece that we know about in BC something, that what works is having good public health, population health mechanisms, and then we can hopefully get vaccines, and hopefully we can get medicines. And I say this while within my group we have somebody working on antisenses, which are a way to wipe out a genetic response for COVID, and at least in cells it looks wonderful. I have a real question whether it'll look nearly as wonderful in humans, and I think we'll stick to a mask, and particularly to my hamster. Okay, Michael, what do you think?
No, I agree. Really, the key until we have better treatments and vaccines is public health. I will say that something else that may carry forward out of this pandemic, a silver lining in the cloud, so to speak, I hope is really a renewed interest in respect for public health principles. We shall see, but I have hope that it will.
And I join that hope. The only thing that I did well in medical school is I came first in the class in preventive and public health. It was the only thing I thought in medical school was worthwhile learning. Clearly, my life took another turn after that, and I bothered to learn some other stuff. But population health, as it's now sort of called by the people in the area, I understand they really like to change names. It's really a huge part. And, you know, the one great thing about COVID-19 is it got rid of air pollution. And, you know, there were those beautiful pictures of basically being able to look at China and look at New York and actually see them when you're looking from space, rather than see the air pollution. So that was the good thing that COVID did. It taught us that we can get rid of air pollution, but we don't need COVID to do it. We just need to change the way we do things. And I think also, Valerie, for basically mental health, I don't know how you feel about it, but again, I think we don't put enough time and effort into providing the support to stop people getting really ill. We tend to treat people when they're ill rather than trying to give the preventive health approach. But I don't know what you feel.
Yeah, I think that goes back to the maybe the awareness, you know, like I said, for me as a therapist, I always want to think on both ends. Is it a physical element or is it a mental health thing, and which one came first? And there's a lot of stigma surrounding that as well. You know, working at the medical school, there's a lot of students that hold themselves responsible on their own for dealing through mental health and hoping that they can figure it out on their own because of the messages they've received. So hopefully through everything that's been going on, there'll be less stigma surrounding mental health, and it'll be more of an open conversation for everyone in all vulnerable populations.
I'll close out by saying two things. You know, it's always right, prison of your own point of view. So definitely the public health concern for me is going to be about the economy. But I'll first say, and this is directed to you, Valerie, that I started the quarantine the day my maternity leave ended. So I have 3 months of isolation on all of you guys, and I was diagnosed with postpartum insomnia. And I did the entire course of my mental health and behavioral health treatment over telehealth. And it was the friend I had in my pocket. And I, you know, finished the course, and it was incredible that I was able to do that. You know, when I had a 3-month-old baby, we did not have childcare until he was 7 months old. You know, I was still trying to work full time, and it was incredible. And so for me, one of the big public health benefits I learned was actually valuing health as an individual, which I probably didn't do much before, even as a pregnant person. But, you know, you just didn't think about it in the same way. And I hope that it brings an immediacy to people's lives to not just have a system facilitate, you know, preventative care, but have people seek it out. And then as an economist, and not as like the new mom who was like trapped inside a house, I'm actually trapped inside a closet right now. I don't know if you guys can tell, this is the nicest closet in our home. But as an economist, I think the biggest public health lesson here is, you know, just how much we lose in our country to inequality. Economic inequality is absolutely staggering. It is at a worse level now than it got right before the Great Depression. And we are entering an unprecedented era in the United States to have a capitalist-based era of inequality. And if we don't bring down that curve, it will be, you know, doctors' pay will decrease, or everyone's pay will decrease except for the highest paid doctors, and you'll just start to see this break in wages, this break in access, this break in affordability and in treatment on every aspect of the economy, the way that we've already seen it. The way that I explain inequality to people is I say that the top 10% income earners in the US, income from any source, not just from their wages, they take home more than half of all of the income in the United States. And so when you ask me what's wrong with healthcare, it's because, yeah, about half of the market is going to be taken up by the top 10% of people. What's wrong with housing? Yeah, I don't need to build houses for poor people. I can build houses for rich people because they buy half of them. And that filters down into so many aspects of the COVID economy, of who has been left behind, who doesn't have the resources. And so for me, it's really just, if we talked about inequality in the abstract, this was a way to bring, again, the immediacy of it and the cost of it kind of more relevant on a national scale. And so my hope is that we can, you know, enact the same type of policies that, greatly reduced inequality for the 30 years that it was reduced between 1940, or 40 years it was reduced between 1940 and 1980. So that is my hope and my mission after all of this.
I think we're running out of time, so a couple of things I do need to do. One, I need to thank all the students who came to this. I think when it started out, we wondered if we'd get 3 students, and quite honestly, it is phenomenal that the students came on a Saturday and spent their time. More phenomenal is really this, not the speakers. You guys are nice, and it was nice of you to give up your time, but really the work that was done by the students who put this together was tremendous. And I think we should all thank them for really putting a tremendous, tremendous effort in. So thank you to the students. You guys were phenomenal. You've done a great job. The problem is I'm now thinking of multiple other areas where we should be doing things like this. So I'm going to come and find you guys again and hope that you'll say to me, well, we don't need any help, which is what you did for this one. And it really was very nice. I was actually terrified when you didn't need help, and you proved to me beyond anybody that you didn't need help, and you were just phenomenal. So thank you all for doing that, and thank you again to the students who came and took part in it.
Right. Thank you to all of our speakers for being here with us all day. And also, I think that marks the end of our full speaker panel Q&A. So now I'm just going to turn it over to David for our closing remarks.
Hello, everyone. Thank you all for attending today's conference. We all hope that you benefited from today's session on the impact of this pandemic on society across various disciplines. We would also like to thank all the speakers who dedicated their time to be with us today and share their expertise with us. A special thank you goes out to Dr. John Morley at St. Louis University for providing us with inspiration for this conference and for supporting us along the way. Just a friendly reminder that we will be sending out a brief survey. We are hoping to publish the data we gather from this conference to help better future education. Please take the time to support us by filling out the survey. If anyone wants to reference this conference or to share it with friends or family who were unable to attend, we will be posting the YouTube link on our website once it's ready. Once again, thank you all for your participation. May you all enjoy the rest of your weekends. Don't forget to wear your masks and stay safe.
Thank you.
Thanks, guys.
Thank you. Bye-bye.
Bye.
Yeah, thank you so much. Goodbye.